Okay, so as I've said, these are a selective cohort of patients with various advanced forms of airway disease who are not doing as well as their referring doctors would like. And in these patients, we proceed with fibre optic bronchoscopy, which involves visual inspection of the upper and lower respiratory tract using a fibre optic instrument, which permits visualization and also lavage out of specimens and also, if necessary, biopsy specimens. Now, this procedure essentially has two very significant problems. The first problem, which I guess is obvious, is that if you're putting a tube, albeit a small one, into the airways, in patients whose oxygenation is already compromised, in other words, their blood oxygen levels are low to begin with, and you're now compromising the diameter of the airways of necessity using the bronchoscopy, the risk is that their oxygen levels are going to fall further. Effectively, in my experience over the past 6 months, and we've done some hundreds of patients at this stage, the high flow system effectively prevents the oxygen levels dropping, which is a huge advantage, not only to the lungs, but also to the other organs as well in these compromised patients. And it also permits us to do the procedures much more quickly, because if the oxygen level drops, you have to stop what you're doing and recover the oxygenation. And that can happen quite a few times in sick patients. It has never happened with this high flow system. The other advantage of the high flow system is that because our patients' lungs are very compromised to begin with, infection is a big problem. Because obviously you're putting instruments through the natural passages into the lung, and of necessity you're introducing organisms, their own organisms albeit, into the lungs, which, as we've said earlier, are a cul-de-sac. So the fact that the air is at body temperature and effectively somewhere nearly 100% relative humidity, room air is usually about 60%, in long-haul airline flights it can be 20%, and low relative humidity impairs the ciliary function of the lungs and it impairs the mucociliary apparatus. And so if you don't have a high flow system which is adequately warmed and adequately humidified, there's this very significant risk of infection after the procedure. And I can honestly say that in the first couple of hundred we've done in the past 6 months, we have not seen any infections. And I think pretty certainly that's because of the conditioned air. That's to say, it's at body temperature effectively, and it's at body humidity effectively. So the two great advantages are you avoid dropping the blood oxygen levels, which can be very significant, and you avoid the most significant post-operative or post-bronchoscopy complication of chest infections.
A significant percentage of my practice is providing anaesthesia and deep sedation for therapeutic bronchoscopies in the endoscopy suite. So the typical challenges with a bronchoscopy are we are sharing the airway with the operator. He has to introduce a camera down into the patient's lungs. He is, by virtue of the procedure he's performing, introducing fluid and saline down into the patient's lungs, suctioning out the large amounts of secretions that these patients have. He has to take tissue samples from the lungs. All of this has to be done in a deeply sedated patient. As a complication of the sedation, these patients aren't breathing, or they're breathing with very shallow breaths. This all affects quite significantly their oxygen levels. So the main complication of bronchoscopy is oxygen levels fall quite dramatically. This is exacerbated by the type of patient that we are presented with during bronchoscopy. The majority of the patients have obviously lung disease, so they are very critically dependent on their oxygen levels. Their oxygen levels will drop far quicker, and more importantly, due to factors such as wheeze and secretions, it is far more difficult to get their oxygen levels back up to safe levels. Also, with increasing frequency, we are being presented with obese patients with high body mass index. This is somewhere where the point high flow has greatly impacted on our clinical care. The obese patient has, by virtue of their disease, a significant number of respiratory consequences. Their oxygen requirements at rest and with any increased workload are greatly increased. Also, by the mechanical pressures of the increased abdominal pressure, their distal lungs are actually quite collapsed. So they've less lung available for oxygenation to occur, and they also have increased oxygen requirements. So when these patients are sedated and a camera is introduced into their airway, very quickly, low oxygen levels, i.e. hypoxemia, results. So particularly in this patient group, the point high flow has revolutionized their care. We can now safely sedate these patients because we are delivering much higher concentration of oxygen down into their lungs. It allows the procedure to be more complex. It allows us to perform bronchoscopy on patients who we previously would have had to exclude, the very high body mass index, the very obese patient, the patients with very severe lung disease. Previously, we would not have been able to perform bronchoscopies on these patients. They would have had to go to the operation theatre. They would have had to have general anaesthetics. So this has greatly impacted our scope of procedure.
If you have any questions or comments, please feel free to leave them in the comments section below. Don't forget to check out our website for more information on high-flow oxygen therapy for perioperative care.